I've gone for the I don't really care approach. Alvaro, I think that's a lovely map. And Max, that is a little bit kitsch, I have to say, but I do like it. I need to see a bit of green. So, you know, is there such a thing as background etiquette in Zoom webinars? Because I know this is a rapidly evolving culture, isn't it?
Yes.
Well, I'll leave that as an open question.
Okay, so we are online. It's 1 minute to 2 p.m. So if you're gonna start as British, we should wait for what, a minute.
Great. It's like waiting for people to arrive at your party. Nobody's come and you start to get nervous. My clock says 2 o'clock, Lucas. Does your clock say 2 o'clock?
Yes, it says 2 o'clock. Just a second, I'm gonna...
Yeah. So Peter's just asking, so we've only got 2 speakers today, but we scheduled for an hour and a half. Does that mean we might be shorter than an hour and a half, or we've got plenty of time to go on? Because I haven't got an hour's talk or 45 minutes talk.
Oh, golly, no. I mean, I'm absolutely fine. I think Alvaro is expecting to talk for about 20, 25 minutes. Yeah. I'm going to talk for about 10 minutes at the start, taking full advantage of the fact that we only have 2 speakers to sort of muscle in a bit. And then we'll just see how rich the discussion is. If we just get a kind of stunned silence, then obviously we won't have such a long session. Hopefully we won't have a stunned silence. So we'll give it up to an hour and a half, but just see how long it takes. Does that sound okay with you?
Yeah.
Okay, Lucas, are we live?
Yes, we are.
Okay, well, hello everybody, whoever you are. Welcome to the latest global platform webinar. And thanks for joining, because I know everybody's incredibly busy and there are so many of these webinars these days. I seem to spend about half my life in webinars on one thing or another. And to some extent, with that in mind, we've reduced the frequency of the global platform webinars. Originally, we were running one of these every week. Now it's about every month. And also, we're trying to add value to all the other discussions that are out there, to focus on issues that other people don't seem to be picking up on as much. Things which are niche, gaps, overlooked. And you know, non-communicable diseases, it seems odd to think of them as a gap or a niche, given the scale and importance of the issue. But correct me if I'm wrong by chat, but as far as I can tell, this is actually the first event which focuses on all the 4 things in this title page on COVID, NCDs, older people, and low and middle income countries. And I think that's quite striking, actually, given how important this confluence of 4 issues actually is as a public health and as a global public health concern. But do let me know if I've missed one. I'd be very interested to know if there have been any other events combining these 4 areas. It's a truism to say that the COVID pandemic is probably one of the biggest global calamities of the last 50 years. By comparison, the pandemics of non-communicable diseases sometimes seem to be looked at as kind of business as usual, a creeping crisis, a slow burning crisis, rather than a global existential threat in the way that coronavirus is. Next slide, please, Lucas. But, you know, if you look just at global deaths, we know that even last year, in the midst of the pandemic, non-communicable diseases accounted for more than 10 times as many deaths at all ages as we think resulted from coronavirus, more than 10 times, even taking into account significant levels of underreporting of COVID mortality, particularly in low and middle income countries. You know, like coronavirus, NCD deaths are strongly concentrated among people at older ages, but not exclusively so. And I think, therefore, for both conditions, this has raised particular concerns about where should we focus our efforts in terms of younger ages or older ages, leading to a lot of controversy and difficult political decision making. But I think that the global NCD agenda, if you can call it that, has had to contend with some quite specific misconceptions which don't apply in the same way to coronavirus. And one of those, and I think it's still there, although I'd like to think that it's been resolved to some degree, is the widely held view that NCDs are mainly conditions that affect rich countries or rich people in poor countries. And of course, we all know that that's an enormous misconception. Next slide, please. Here we have data specifically referring to people aged over 60, looking at different causes of death. And if we just focus on CVDs, cardiovascular disease, we can see that the impact of CVDs, this is using data from, I think, 2012 Global Burden of Disease, in low and middle income countries in the dark green, was far greater than in high income countries. So this is both the impact on foreshortening people's lives and on how well they are while they remain alive, combined into a disability adjusted life year measure. And this, of course, you know, these are absolute numbers, and we have to bear in mind, of course, that the populations of low and middle income countries are considerably younger still than those of high income countries. So that's even more striking, the concentration of DALIs resulting from things like CVDs in low and middle income countries. So I think in the face of this kind of overwhelming data, that view that NCDs are conditions of affluence has receded to some extent, but not as far as we might like to think. And last year I published a paper looking at the health of older people in sub-Saharan Africa. And it included a review of published studies. Next slide, please, Lucas. And what I found was that, you know, it was very dominated, the research, you know, by concerns about HIV and TB, and to some extent other infectious diseases among older people. And yet, when you look at the global burden of disease data for 2016, you can see again that the vast majority of ill health and early loss of life for older men and older women were accounted for by NCDs, by non-communicable diseases. And to some degree, I argued in that paper, there appeared to be a kind of disconnect between the broad epidemiology, if you know what I mean, and the focus of research and policy and discourse. And I do wonder if we might see something similar in terms of COVID and NCDs for similar reasons. A more persistent misconception about NCDs is that they're not easily treated, or they're very expensive to deal with. And of course, again, most of us know that's not the case. So, for example, if we were just able to improve the coverage of screening and basic treatment for things like hypertension, we could save millions of lives of people of all ages, especially older people, around the world. And that isn't expensive. Next slide, please. This is a rather complicated chart. I don't normally use complicated charts in presentations, but I've made an exception here because I think it's quite useful to support the point I want to make. It comes from a study I participated in with colleagues from Lund School of Hygiene and the Pan American Healthcare Organization that was published last year. And what it's trying to do is distinguish between causes of death which could be understood as being avertible one way or another through good treatment or through prevention, and those which are considerably less potentially avertible, using a fairly well validated methodology which has been used in a number of other studies. And then what we do is we apply that specifically to NCDs, people of all ages around the world. And the idea is that we want to look at the red, not the pink bars, because those are deaths which theoretically at least could have been avoided. And so it doesn't really matter if you focus on the left or the right here, because the data for men and women are pretty similar for the purposes of my argument. So if you maybe just focus on men to the right and on the lower chart, what that tells you is even for people at old ages, the great majority of NCD deaths that occurred in 2017, you can argue about our methodology, but applying our methodology would have been defined as potentially avoidable or avertable. And if you look at the top chart, this is counting millions of deaths. It's not a percentage. It's saying that if you looked at all the potentially avoidable NCD deaths that happened in 2017 for people of all ages, the dark red bits are the ones that were avoidable again. You can see that the vast majority of those avoidable deaths occurred at later ages. So this was very important for us to try and challenge this argument that actually there's not a lot you can do about NCDs. They're really hard to prevent or they're very expensive to treat, etc., etc. And there's a lot more in the paper. We were very excited about this research. Unfortunately, it was published in March 2020, not the greatest month to try and publish research on NCDs. And frankly, we were all too busy and distracted and upset, as were other people, for us to really be able to take this work forward or build on this in the ways that we'd hoped to do. And it does, I don't think that's an unusual experience for a lot of people who wouldn't normally, well, why would have been working on COVID in the past, since it didn't really exist in terms of novel coronavirus. But it raises this question, I think, which is whether coronavirus, maybe for good reasons, maybe not for good reasons, is crowding out research and policy focus on things like NCDs to an extent which could actually be problematic. Clearly, both issues, both conditions, coronavirus and NCDs, are hugely important in different ways. Coronavirus might not be killing as many people, but it's clearly having a huge impact on the well-being of the entire planet in many, many ways. But we mustn't lose sight, despite the importance of the pandemic, of the importance of NCDs, and nor must we put them to one side for a little bit, saying, well, we'll wait until things get kind of back to normal and then we can start to worry about NCDs again. I think that's a very dangerous thing to do. What we need to do is think about how we can address the crisis of NCDs in the midst of the unfolding COVID pandemic. We also need to look beyond the pandemic, whenever that might be, because I think the pandemic will have a huge legacy on future attitudes towards public health and health services. And thinking about NCDs and older people, I think this will pose both opportunities and challenges. Societies may be prepared to invest more in health, which of course is a great thing, but they may also be much more focused on infectious disease, vaccines, giving resources to intensive care units of hospitals, things like that. And of course, none of those things are particularly helpful in terms of preventing and treating and managing non-communicable diseases. So I think we need to try to think about NCDs and COVID as of now. And I think one way to start engaging with these issues is to look at how the harms being generated by the pandemic and NCDs reinforce each other in different ways. Next slide, please. And again, I don't think there's anything I'm saying here that you're not familiar with. Clearly, we all know that many NCDs and many risk factors associated with NCDs, like smoking or obesity, are strongly associated with severe outcomes from COVID infections. And we know that when people become very ill with COVID, if they've also got non-communicable diseases or they develop them, the two interact so much that it's often actually very hard to say what was the primary cause of death. Did they die of a stroke? Did they die of COVID? So this just shows how difficult it is to disentangle these issues. Of course, we know that the pandemic has led to huge disruption for screening and treatment of NCDs, and that's generating already a lot of excess mortality, which will continue. And we also know that the more indirect effects of COVID, the lasting effects of things like non-COVID on susceptibility to NCDs, but also those wider effects of lockdown, economic impacts, stress, lack of exercise, etc., are going to be major drivers indirectly of exposure to NCDs in future years, particularly the social determinants of NCDs. So I think these clearly show why we need to look at COVID and NCDs at the same time and not park NCDs and come back to them later. Next slide, please. I would very much like to talk about how these issues are, oh, sorry, go back to the previous one. Ah, yeah, the red bit. Are playing out with specific reference to older people in low middle income countries. I haven't really said very much about that. And the reason I haven't said very much about that is I haven't been able to find out very much about that because there's almost nothing being published about it, which kind of goes back to my previous concern about research and policy focus being crowded out to some extent. So that's why I was delighted to be able to put together this particular session this week. And next slide, please. And to bring in two people who I don't want to big them up too much because that puts them under a lot of pressure, but I think they are very well placed to be able to tell us at least some things about some of the issues that I've been scratching my head about. So I'll introduce Max and then I'll come back to introduce Alvaro, who will be giving the second paper. Max, like me, is based at the University of East Anglia in the UK. He's an epidemiologist, but he sort of does more than just epidemiology, and he has a vast range of experience working on infectious and non-communicable diseases, particularly in low and middle income countries. More recently, he's had a particular focus on multimorbidity, and he's also very interested in ways to improve primary healthcare services for people of all ages. And so I think his experience and his expertise fit very nicely into today's focus, today's agenda. So without further ado, Max, the floor is yours. Thank you.
Thank you. And I'll try and control my, Lucas, can you let me share the screen? Okay.
Yes, Max, you should be able to do it.
Okay. It says, well, other parts. Peter, you have to close yours.
Oh, sorry.
Okay. Okay.
While Max is uploading his presentation, just let me know. I would like just to tell people, all participants, that we're broadcasting on YouTube, also this webinar, and you can ask questions on the Q&A and in the chat and also on the YouTube. And I will be looking at the questions, and at the end, we'll be addressing in the discussion. Sorry about the interruption, Max.
Okay, thank you. Well, thanks, Peter. So, as Peter said, I do lots of research on TB, HIV, and NCDs in South Africa in primary healthcare. But when Peter asked me to speak on this topic about 7 or 8 months ago, I said I didn't actually know anything. We didn't have any evidence, so I would only waffle. But what I would like to do is just share a bit of information or research that's been coming out about NCDs and COVID in South Africa. It's not a complete picture, but it does give us some insights. So just a bit of background on South Africa, for those of you who don't know. So it's one of the biggest countries in Africa with about 58 million population. It's a middle income country, but it's also one of the most unequal countries in the world. And it has, partly for those reasons, has a very high burden of HIV and tuberculosis. So South Africa, according to official COVID statistics, has had the largest number of cases and the largest number of deaths due to COVID in Africa. But in fact, it's a lot worse than the official figures show. Now, this graph is from the South African Medical Research Council, and it's a report on both COVID deaths and excess deaths over time. So the red line and the area under the red line is the number of deaths that have been attributed to COVID. Basically, people have died with a positive COVID test. But the blue line above it is what we call the excess deaths. And excess deaths are the difference between the total number of deaths and the numbers of deaths that would be expected at that time of year, based on previous years. And you can see the total number of excess deaths is much higher than the COVID deaths. So South Africa up till now, till the end of January, has had 133,000 excess deaths, which in terms of the population in deaths per million is actually 40% higher than the total COVID deaths or the total excess deaths in the UK per million population. So even though UK is held up as one of the worst countries in the world with effects of COVID, South Africa is actually much worse. It just doesn't get that because that attention, because most people who die haven't been tested. Of course, some of these people might not have died of COVID, so they might have died of COVID without being tested, or they might have died because of lockdown and other disruptions prevented them from getting the healthcare that they needed for other conditions. Now, one of South Africa's health problems is a very high prevalence of overweight and obesity. So it's estimated about 28% of all adults are obese, but that comes down to almost more than 2/3 of women aged 15 or over, and about 1/3 of men are overweight or obese. So that drives a lot of the problems with non-communicable diseases. So this is, I'm presenting a couple of studies that I've been involved in from one small area of South Africa, which is in rural KwaZulu-Natal. And this is an area that's not particularly typical. It's quite poor. It has very high HIV prevalence, but it does give quite useful information in an area that's quite underrepresented in official statistics. So this is really based on surveys. Most of these conditions are based on whether people have report having ever been diagnosed or treated with these conditions. Now, if you look up in the top right-hand corner, this is giving the prevalence of hypertension in men and women at older ages. And you can see what it shows is among women aged 70 and over, 80% of them report having hypertension, and it's almost as high in men. And in all women over from age of 50 onwards, more than 70% of them report having hypertension. So that is a very high rates of non-communicable disease. If you look on the bottom right, these black lines are the prevalence of diabetes in men and women at older ages. So it's much more common in women than in men because of higher prevalence of obesity. But you can see that coming up there, and men catching up with women at older ages. On the left-hand side, you've got this hump here, and that's people with HIV at different ages. So you can see HIVs mostly in younger people. Diabetes and hypertension is in older people, as you'd expect. And then you've got this group in the middle, aged between about 40 or 50, where there's quite high prevalence of all of these conditions. So that's where you'd expect to see more multimorbidity, or people having communicable and non-communicable disease at the same time. Using the same data and just restricting it to people aged 40 or over, these graphs, these Venn diagrams really just break up people according to whether they've got diabetes, hypertension, or HIV, and how much overlap there is between these. So what's striking about this is that 2/3 of these people aged 40 and over, 2/3 of them have at least one of these conditions. So almost nobody has no diabetes, hypertension, or HIV. 32% of people with HIV also have hypertension, and then 13% of people with hypertension also have HIV. The reason it's low is because most people with hypertension are older, and HIV is less common in older people. Now, I'd like to, going back to COVID deaths, now this is other research conducted by colleagues in the Western Cape and the University of Cape Town. Now they have some of the most remarkable health service and epidemiological data in Africa, because they have data from from medical records from everyone using public health clinics and hospitals in the whole province. And that's just about everyone does use them because they can't afford private health care. And they also have a very good system of working out what people's diseases people have based on what tests, treatments, diagnoses have been recorded. So this is looking at what contributes to people dying when they get COVID. Now, the middle column, that's the first set of figures there, are restricted to anyone who's had COVID diagnosed or tested anywhere. So most of these people would have been tested in primary healthcare facilities. And then saying, among those people, how are these various risk factors associated with the risk of dying? So I'll just go through these slowly. So at the top, you've got men, 50% more likely to die. I should explain, this is a hazard ratio, which is otherwise known as a relative risk. So it's a 1.5 means that you're 1.5 times as likely to die if you're male compared to if you're female. And then the age compared to people 20 to 29, you see a very steep gradient of risk. So over 70-year-olds are 38 times as likely to die as people 20 to 29. So that's a very steep curve, but it's quite similar to what we see in other countries, including the UK. Now, this is important. So diabetes, people with diabetes are 2.2 to 3.6 times as likely to die. There's a range of figures there depending on how well their diabetes is controlled. This is reassuring. Hypertension, not associated with risk of death at all. But chronic kidney disease, double the risk of death, and some of that would be caused by hypertension. Also reassuring, possibly surprising, chronic lung disease, that's asthma, chronic obstructive pulmonary disease, not associated with death. And this is very important. This is the only evidence that I know of from Africa, or even from the whole world, of how TB and HIV affects your risk of death. So we see both previous TB or having current TB is associated with 60% higher risk of death, and HIV 1.7 times. So they're bad, and we would have expected them to be bad, both because TB is obviously damaging your lungs to start with, and HIV impairs your ability to fight off infection. But you can see these are much smaller effects than something like diabetes or chronic kidney disease. I'll go on to the next set of figures here, what we call hospitalized cases. So these people are sick enough to actually be admitted to hospital where they have quite a high risk of death, whatever risk factors they have. And again, males slightly higher, not such a steep gradient of death, but you could imagine that it's, even if you're 20 to 29, to be admitted for COVID, you must be pretty sick to start with. Diabetes, again, increasing your risk of death. Hypertension, chronic kidney disease, chronic lung disease, not associated with death. And previous TB and HIV also associated with increased risk of death. So that's original evidence really showing how communicable and non-communicable disease both influence the risk of death if you have COVID. Going on to a couple of smaller studies we did in the same area of KwaZulu-Natal that I mentioned. So trying to see, we were very concerned that the effect of lockdown in South Africa, which was very strict in the first few months, and then got lifted steadily in stages afterwards. We were very concerned that this would prevent people from going to clinics and getting the treatment and management they needed for their NCDs, and particularly among older people. So what these graphs show are what you have here. The red line is the time in which the lockdown started, which was late in March, I think. The time before that is the trends in average daily numbers of patients visiting each clinic per day. And what we see here, just going down slowly, a very small decrease during the first stage of lockdown, and not much change after that. This was very reassuring. We saw absolutely no change in people coming for chronic disease management, chronic care, and that's largely diabetes and hypertension, also asthma, lung disease, etc. So no difference, and very little effect, it seemed, on older people. They still keep coming, a slight decrease in daily attendance at clinics, but not very much. Where we did find a difference was among children. So it seemed to be a particular problem with children aged under 5 who are less likely to be going to the clinics. Looking at the local hospital, similar sort of analysis. So just looking at the number of people admitted to hospital for communicable diseases before and after lockdown. You can see a slight increase in communicable disease at the start of lockdown, but then no big change after that, and seemingly no effect on non-communicable diseases. What we did find with the hospital data is that in the first period of lockdown, the likelihood of dying if you were admitted to hospital went down quite sharply, which suggested that people with the most severe conditions who were at risk of death weren't being admitted to hospital and might well have been dying elsewhere. So that's just some pieces of data, pieces of evidence that are coming out about NCDs and COVID in South Africa. And while it's not a complete picture, it does give you some main points. So the one is reinforcing what Peter was saying in the introduction, that obesity, as well as NCDs and HIV, are all common in South Africa. So is multimorbidity. That COVID has caused many more deaths than the official COVID data show, and that the risk of death if you get COVID is increased by diabetes, kidney disease, HIV, and TB. But at least in this area, the small area that we studied, there didn't seem to be a big problem with access to primary health care for NCDs or for older people. There might have been difficulties for people getting there, but they still came. This might be different in other settings. One thing that COVID has done, which could have a beneficial lasting effect, is throughout the country, there's been greater attempts to try and work out ways of delivering chronic medication for people with NCDs in ways that they don't have to spend as much time or even come to the clinics, where they, being older people, are at high risk of being infected, and also because they've got NCDs, then being at high risk of dying because of COVID. So some of the attempts have been, for example, instead of expecting patients to come every month to collect their drugs, making up packs of 3 months supply of drugs. Also attempts to deliver drugs outside of clinics through community health workers or through pickup points outside of health facilities. I don't think those efforts have gone that far. They've been more successful in some places than others, but it gives impetus on the sort of change in management of chronic diseases, which should happen anyway. This has been very stressful for health workers. I haven't shown you any data on that, but we've been surveying health workers on the experience of COVID and finding in primary health care, also in KwaZulu-Natal province, very high rates of reported stress, poor quality of life, and a very high proportion of them having actually had personal experience of COVID. So we surveyed primary care staff in one district and found 20% of them had previously been diagnosed with COVID themselves. They were very worried about getting COVID, infecting their families. very worried about the work stresses of managing COVID clinically. And 70% of them had had a personal experience of COVID, which includes being infected, having a family member infected, having to quarantine, having a friend or family member who died or been admitted to hospital. So there's a real stress on primary healthcare workers. So the mental health of health workers is also a very important part of the response to COVID. So thank you, Peter. That's all for me.
Thank you so much, Max. That's really great. And it's clear that the research is taking place at the moment and the papers are on their way to address some of the issues that I set out at the start of the webinar. We'll be taking questions and having discussion related to Max's presentation at the end of the webinar, like we usually do. So without doing that, I'll just move directly to introduce Professor Álvaro Cruz, who is a professor of medicine in the Federal University of Bahia in Brazil. He's got a vast amount of experience, not just in Brazil, but globally, looking at respiratory diseases, including asthma, COPD, and other conditions. He's also, I think it'd be fair to say, he's a leading global actor in NCD and respiratory disease agendas, working very closely with organizations like WHO, for example, by being a leading member of the Global Alliance Against Chronic Respiratory Diseases, which has been developed, as I understand, as a joint activity with WHO. So again, I think Álvaro has got particular expertise and insights which should be able to shed some light on these issues. And I'm incredibly grateful to Max for introducing me to Álvaro, and for Álvaro for agreeing to make time in his busy schedule. So thank you, Álvaro. Over to you.
Thank you very much. I'm pleased, very happy to take part in this very interesting seminar with my good friend, Professor Bachmann, and to know and follow Professor Lloyd Sherlock. It's really going to be very interesting to discuss this subject, which is absolutely relevant. Let me share my presentation, and I'd like to tell you that I am not a gerontologist. I'm not an epidemiologist either, but I'm a clinician, a specialist in respiratory disease who values a lot primary health care, public health, some research. So I'm going to present to you some of my experiences in this field, which relates to the subject we are discussing today. Well, this is a piece of my city, the city of Salvador in Bahia, northeast, poor region of the country. And you see, unfortunately, we compete with South Africa among the countries in which there is more inequality. And the majority of the population in my city and many other regions of Brazil live in this sort of environment, which is not for the most poor. This is, I would say, lower middle class. And I can tell you that I was absolutely afraid. I was really much concerned about the consequences of COVID in this sort of environment. I think the attenuation we have for the consequences of an epidemic like this in Brazil in general is that we have universal health coverage by our healthcare system, which tries to copy the health system of the UK. So this is a protection. As you're going to see, as you know, there was a disaster, but it has not been a catastrophe. Things are moving. So let's see more of what happened here. This is a little conflict of interest disclosure. I think Peter was very accurate in describing, making my presentation. I'm connected to several initiatives in Brazil and outside related to research and public health in non-communicable disease. Well, I divided this presentation in 4 topics I wish to cover quickly. The dimension of the problems: asthma, COPD, and COVID. COVID mortality, asthma, COPD, and the elderly. Asthma and COPD exacerbations in times of COVID-19. And finally, why asthma and COPD exacerbations are reduced, as you see in Brazil. So these are the figures of the tremendous suffering Brazilians have undergone related to COVID. Almost 10 million cases and over 200,000 deaths by February 4th, 2021. And as you see clearly, the first wave was declining, and then came the second wave, which has picked over the first wave. This is what we are facing now. I've seen many more patients recently than I saw in the first wave, no doubt. Hopefully the mortality or the lethality is not over what it was before, perhaps because we have learned a little bit on how to deal with the problem, but it may be a little bit afterwards. There may be a delay in picking up the deaths. Well, what is the frequency of COPD in Brazil? The data we have is from São Paulo. For people over the age of 40, about 15%. This is a study from 2005. It was published 2005. Things have not changed that much, I think, although there is a decline in smoking in Brazil, very remarkable. And as everywhere, we mix problems and some good solutions. So I think controlling tobacco in Brazil has been a good positive thing. Well, for asthma, we have a lot of asthma as well. This is a study that we published in 2012, analyzing data from a study performed by WHO in adults to look at asthma in 70 countries. And Brazil is here in red because it has a prevalence of asthma in adults, asthma diagnosed by a physician over 10%, around 12%, which is the same as we have shown in children and adolescents in general. So the expected decline in the prevalence of asthma from childhood to adulthood is not that clear. So it's a major problem. And we were, again, very much concerned in a country with so many people with COPD, a disease that affects people over 40, and asthma, which affects people all over the place in terms of the age distribution. What could be the consequences? As we know, respiratory infections are usually the main cause of exacerbations due to this disease. So infectious disease and chronic disease in respiratory medicine are all mixed, always. Well, this is another reason for concern. A document from the American Thoracic Society published some years ago, calling attention to the problem of asthma in the elderly, and which is more severe and difficult to manage due to effects related to aging or effects related to asthma itself. So another reason for concern in people with asthma and aging if they had COVID. Well, let's see what are the facts. Taking data from São Paulo in a much more simple analysis than what Max has presented. So this sample of 42,000 deaths in the state of São Paulo last year, there was a little bit of a predominance in males. The age distribution is striking. Almost 80% of the deaths occurred in people with an age of 60 or above. And here are the comorbidities that were observed among those dying. 80%, at least one comorbidity identified. 60% had cardiovascular disease in general, including hypertension. 43% had diabetes mellitus, 11% neurologic disease, including stroke and post-stroke conditions, and 9.4% with renal disease. So it was surprising not to see respiratory disease, chronic respiratory disease among the leading comorbidities. So lung disease, any lung disease, so most chronic lung disease, 88%, obesity, 8%, immunosuppression here, 5%, and asthma, only 3.1%, whereas we know that the prevalence is above 10%. Well, I decided to look at the database of the Ministry of Health to see what was happening in terms of hospitalizations in the whole country. So first, for COPD, you see here hospital admissions in a period of 6 months in 2019 in blue, dark blue, and the same period from 2020, from April to September, the peak of the initial wave. And as you see here, there was a clear reduction in hospitalizations in the year, in the whole country, from 60,000 to less than 30,000. And if you look at each of the regions of the country, the same phenomenon happened. Why is this? We will discuss later on. We may learn a lot important things from this. Now, asthma, the same sort of analysis, 2019 in dark blue, 2020 in red, from April to September, the initial wave. 45,000 hospital admissions, 19,000 the year after, less than half. And the same has happened in every region of the country. Why is this? Well, we have observed other remarkable facts, some not published that I will comment to you. This is a study we are conducting over the years. We have a cohort of people with severe asthma, and we compared this Brazilian cohort. We follow up in Salvador, we call PRO-R, and we follow these people. Looking at these individuals that we follow over many years, we haven't gotten many reports of major problems among them. We follow up some 1,000 of these people with previous severe asthma, and the very few of them were hospitalized and or died to our knowledge. So some may not have been reported, but it doesn't seem to be a major problem. And this is the average age of the patients we follow in this cohort. So it was about 52 years old 5 years ago, so they are close to 60. And still, we haven't seen much of a problem among them. Well, there's another observation that I think it's worth sharing regarding asthma and COVID. This is another study. This is a different cohort. It's a study we were beginning. It's funded by NIHR. Max is a collaborator, an important collaborator of this study. And we would try to test the efficacy, the effectiveness, and of an intervention to build capacity of primary healthcare workers for dealing with asthma. But this was interrupted by the pandemic. And we looked at their initial observation we had. So a sample of around 200 subjects. And we have here the number of severe asthma exacerbations 1 year before from the reports of the patients. And now we have the rate of exacerbations the year after the pandemic, this data is annualized because we don't have 1 year of follow-up to everyone. But it's striking the intervention, the reduction. Of course, the intervention we planned was not completed, so both groups were followed up by telephone interviews, as we couldn't follow them up personally in many situations. So this is in agreement with the data from the hospitalization I just shown to you. What are the possible explanations for the reduction of asthma exacerbations? Well, they may be related to asthma or to its treatments. Atopy may reduce the risk of COVID. It's a question. There are some reports suggesting this may happen. Inhaled corticosteroids used to asthma might prevent SARS-CoV-2 infection. There are some reports on that. And inhaled corticosteroids could attenuate the course of the disease. Well, this has been hypothesized, but we don't have any clear, strong, robust evidence on any of these. Patients' behavior, better adherence to treatment. We have some evidence of this, and I think this is something that is worth pursuing, and it's a lesson we may learn for the future. Fear of attending an ER due to COVID-19. Well, we thought this could be happening, but from the data on hospitalizations and the data on the follow-up we have in our boards, it doesn't seem to be the major problem. And some related to the health system, reduce more priority to asthma. Well, this could be. And reduce availability of beds. This could reduce hospitalizations. Yes, but it doesn't seem to be the major problem. Well, some more possible reasons related to public response to COVID-19, social distancing, use of masks, reduced traveling, closing of schools, home office practices. All of them could result in less acute respiratory infections, which could be the reason we have less asthma exacerbations and less COPD. So about the same possible reasons or explanations we could claim for COPD. And I think these factors should be investigated, because if we manage to have this sort of effect in preventing exacerbation due to asthma and COPD, this has major implications to health, well-being, and costs, and mortality. Well, we have faced major problems in Brazil, a nation divided by politics, and we are fortunate to have a leader which is completely against science, against anything that comes to support prevention of COVID, regretfully. In this sort of situation, he has taken part in demonstrations during the pandemic. He has fired one minister of health, the second minister he had appointed resigned, and we have a general in command of the Ministry of Health doing what the president wishes. It's really terrible. Well, let's see a measure of social distancing in the city of São Paulo to tell you that in the beginning there was some social distancing, then right after around the end of March and May, April, May, and so forth, with the president that invites everyone to go to the street, to work, to continue with no care. The average index of social distancing in São Paulo has been around 50%. So there has never been a lockdown. There were many individuals that took precautions, but in general, it was a very limited social distancing, I would say. But there were other sorts of response we had in Brazil that helped controlling the pandemic and its consequences. And this is just an example. The scientific community was a pioneer in studying people that died with COVID, did autopsies, and have shown the important components of vascular disease associated with COVID. Very important, as you know, thrombotic phenomena. We had other very interesting initiatives. As I mentioned, university public health covered its importance. We had some cash transfer to people that could not work, and then this was approved by the Congress, and the government has offered a very small amount of funding, but it was important. Also, there was some incentive for the employers not to fire their employees and keep them working with support from the government. And many municipal and state level initiatives, war hospitals, shelters. And we've seen here where I live, the governor from one party and the mayor of the city of Salvador from another party working very well together towards better care, better social assistance in times of COVID. Some other examples of a very strong response to COVID, which has attenuated the problem in Brazil. There is a service we developed in Bahia, mostly from Fiocruz, a foundation. We have one of the headquarters of the Northeastern region is in Salvador. We developed this telecoronavirus 155 for people to call and get instructions on whether they should go to see one of the health facilities or to stay at home, and give them some reassurance and guidance, general guidance, using medical students mentored by more experienced professionals. The experience was accepted for publication. It will be published soon. São Paulo University Hospital complex offered 1,000 beds exclusively to COVID-19, including 300 beds for ICU. This is another network of institutions in Bahia called Covida that has been reporting on data analysis from different cities and states in Brazil. There was some concern the ministry might not do its job well. And there is this initiative, SOS Favela in Rio, trying to report what happens to these underprivileged populations. Now, some thoughts I wish to share with you before I conclude about low and middle income countries, health in general, COVID and CDs. In Brazil, we have exactly this scenario that Peter and Max have highlighted, a combination of multiple problems, poverty, and although there is universal health care, there is limited quality, as you may imagine. So I think it's important that everyone understands that hospital beds and ventilators are not enough. They are necessary, but they are far from being sufficient to deal with the problem. Social distancing has to be taken seriously from the beginning and throughout the end. Again, the vaccines will not solve the problem completely. Collaboration is key to planning strategically and preparedness. The capacity for research in low and middle income countries, surveillance and manufacturing essential products is crucial. And WHO, despite of its problems and limitations, is vital for global health security, coordination, and response. Now, some more general thoughts. respiratory infections are a major threat to mankind. I think we have to understand this and keep thinking about how to deal with this threat. Cannons and bombs are useless to fight it, but science, solidarity, and sharing knowledge work. Political leaders must engage with health authorities, not fight them, as we see in many countries, not only the low and middle income countries like Brazil. Health is the most precious asset one has. Many people keep forgetting this, but I think COVID has reminded many of them about this. Health problems respect no border, and everyone must be cared for to protect all. And finally, top priority has to be given to protect respiratory health, hopefully in a cleaner and greener world. Well, to summarize what I've been discussing with you, I think I can say COVID has affected over 9 million Brazilians, a country with a 12% prevalence of asthma and 15% prevalence of COPD in those over 40 years old. COVID killed over 200,000 people. Some 75% of them are over 60 years of age. Asthma and COPD are underrepresented among those dying of COPD. Asthma and COPD exacerbations and hospitalizations have been markedly reduced in times of COVID-19, surprisingly. And it is likely the reduction in asthma and COPD exacerbations is related to a reduced frequency of acute respiratory viral infections due to social distancing measures. And I think we must learn with this to try to keep it low after COVID times. Well, in conclusion, I think we all agree we need constructive, wise leadership to inspire people to understand we are all on the same side. This is a picture composed by small pictures of healthcare professionals that have died. And I always think of Nelson Mandela, and I think he's an example that we need to pray that other political leaders learn from. Thank you.
Well, thank you so much, Alvaro. That was great. I have got loads of questions for both you and for Max, but rather than abuse my chair's privilege, I'm going to invite Lucas to chair the question and answer session. So I will just be a regular citizen with my own questions without any kind of priority status. And Lucas, if you wouldn't mind simply fielding questions which people can either raise their hands, and I think some people have already done that, or they can put their questions through Q&A or chat, and Lucas will pick those up. So let's see what we've got.
Thanks, Peter. So I would invite everyone to ask your questions. You also can ask questions, Peter, as you mentioned. There was a question at the beginning of the presentation asking about proportions of non-com and com disease deaths, and asking for an ideal proportion of non-communicable disease. And I think, Peter, you tried to answer. Could you summarize your answer, please?
Well, the short answer is it's really hard to answer that question. I guess the country, certainly when you look at the health of people at older ages, which probably does best, is Japan. And the leading cause of mortality for older people in Japan is pneumonia. And that's because, of course, everybody has to die of something. And pneumonia has a particularly high impact on people at very old ages. So yes, everybody has to die of something. In the research that I referred to, where we look at avertible versus non-avertible NCD deaths, we also, and I didn't present it because it would have been more complicated, we focus on a measurement which is called years of life lost, which says that anybody who dies of a particular thing at a particular moment in time would have been expected to live a bit longer otherwise. Now, that might have been 6 months. If they were already extremely old, it might have been several years were they somewhat younger. And our argument is that what you want to do is minimize lost years of life across an entire population for conditions that could have been relatively easily averted. So that is how we would approach this. So calculations of years of life lost normally refer to a country with very high life expectancy, again, like Japan, for example. And so in a way, the argument about what proportion of non-communicable versus communicable disease deaths is a bit of a red herring. It so happens that if people live for a very, very long time, certainly taking the example of Japan, they're more likely to die of pneumonia than of stroke, because Japan has done an awful lot to control hypertension in its population, and that's been a major contributor to its very high life expectancy at old age. Thank you.
Very good. I have an initial question for Max. I was curious about the hazard ratios. The chronic lung disease, it's not associated with deaths. Is there an explanation of why that could happen? Is just a statistical artifact, or is there another set of reasons?
Well, I don't know the actual reason, but it is compatible with what Alvaro was saying, where we're not getting, actually in Brazil, they're actually getting big reductions in deaths and admissions due to chronic lung disease. So I think, so it might be something about access to health services, but I think it's probably more to do with the sort of pathophysiology of COVID. And the way that we thought it would. It does cause pneumonia because of sort of immune responses, but it seems the sort of damage that you get to the lungs with COPD and asthma are not the sort of things that the COVID virus actually interferes with. So it's has much more effect on, for example, on blood vessels that have been damaged through diabetes, for example. So, that's the pathophysiology isn't my area of expertise, but it does show that that form of lung disease is not, it doesn't seem to be very worrying. I mean, the other thing is it also might be that COPD particularly and asthma are underdiagnosed in South Africa. So there might be a lot of people who have the condition but just haven't been treated for it. So it might just be that could be partly a data artifact. On the other hand, things like kidney disease probably are underdiagnosed as well. So it's complex question, but it is slightly surprising. When in the started, we thought people with chronic lung disease would be really at very high risk, but it doesn't seem to be the case. And I think, perhaps Alvaro could comment. Generally research from, say, developed countries where there's very good data, and does COPD and asthma increase risk of death in those countries, Alvaro?
Well, the numbers, Max, are you have all over the place. There are some studies showing increased risk with asthma, especially more severe asthma, and also COPD, many studies. But it may be related, in the case of asthma, to the use of oral corticosteroids in the most severe cases. I think it's in the recovery study in the UK. I'm a little bit confused with so many acronyms now, but the use of oral corticosteroids is related to risk for favorable outcomes. But I agree entirely with your comments on the possible reasons for the asthma and COPD not being risk factors for death, for instance, in the case of COVID. There may be some reasons related to health system to assess, but I think it's mostly the fact that COVID doesn't hit the airways hard, and asthma and COPD are disease of the airways. It hits the deep tissue of the lungs, the alveoli and the vessels. And this is not a problem usually in asthma or COPD, so it doesn't really make COPD or asthma worse. And on the other hand, people may use their medication more carefully, be aware of social gatherings, and reduce their risks of getting COVID.
That's very interesting. And Alvaro, you raise a topic about health services, and I would like to ask you both. In the UK, for example, in what happened with the primary care services is at the beginning they stopped attending people. They just said, okay, just call us. Don't come visit us. If you have something urgent, go to the hospital, but if not, just wait. I think that approach happened in many countries. We could say that it's problematic in many ways. There's people that need follow-ups, that need prescriptions, that has not necessarily a simple condition to treat. But I would like to ask in the opposite way. Do we know of good examples of public policy approaches where health services could follow up NCDs, could do proactive, not just, oh, let's protect ourselves from COVID, but let's provide something to the wider community with NCDs? Do you have any knowledge of that?
Okay, yeah, perhaps I'd start. So I did mention briefly that I'm aware, at least in certain clinics, some clinics run by NGOs, which are really piloting sort of new initiatives in South Africa, but also in some government services where they have been trying to increase delivery of drugs through community health workers and also decentralized delivery of drugs. This is actually, there is a national program in South Africa of doing that. It's of having sort of centralized packaging of drugs, pre-prepared and delivered through, for example, pharmacies or community pickup points, or even shops in towns. And those are great examples where they've worked. People really like them. But I don't think South Africa's at a stage yet where it's actually doing it on a large scale successfully. But having done some research on those programs before COVID, it did seem it's a way to go. And I can only say anecdotally that I've been told that at least in the Western Cape, for example, that many of the primary care services have tried to do that. So deliver drugs off-site, and also, as I said, giving people 3 months worth of drugs rather than expecting them to come into the clinic every month. But I hope to get to, in a few months' time or later, to actually have more evidence of that, because I think this is COVID is pushing in the right direction in that way.
Max, in the context of our research projects in ProAR, we are trying to do the same, and also offering people telephone consultations and WhatsApp video consultations, which helps in extending the validity of the prescriptions for them to pick up in the pharmacies. You may know that in Brazil, people pick up medicines in the private pharmacies in a program subsidized by the government for chronic disease, including asthma, COPD, diabetes, and hypertension. So things have moved trying to help, but I think there was such a major disruption in the healthcare system, including in affecting the healthcare professionals, that things are really far from ideal. So I'm not sure. I think this sort of practice may have attenuated a little bit the problems, but I think there will be problems with the people with chronic disease not properly managed.
Thanks, Alvaro and Max. Peter, have you raised your hand?
Oh yeah, thank you, Lucas. Yeah, I just want to follow up on a couple of these points. One of them is clearly the research is starting to emerge, which shows that relationships between different kinds of NCDs and COVID case fatality rates are inevitably going to be very complicated, because NCDs are a very complicated bunch of things, and that to some extent they may not follow what we would have expected, particularly with reference to some of these respiratory conditions. And it's also very interesting the degree of strength that of the association between diabetes and risk of COVID mortality, case fatality, from Max's study. Very, very strong effect. And I guess, of course, this is rapidly evolving knowledge, and we may be talking, we may have very different results and findings in a few months' time or in a year or two's time, but this is what we know at the moment. And I was just thinking about the wider implications of this. So, for example, in South Africa, and actually a very specific question I have for Max about diabetes, is this based on self-reported diabetes, or were people actually tested for diabetes? Because in that sort of DHS site, I suspect there will be a significant group of people who are unaware that they're diabetic, and that would affect the result. But aside from that, if we assume that this is a very robust and large association, is this something that's been communicated to people in public health, to the population at large? Is there an awareness that diabetes is much more important, it would seem, than hypertension? Could you even go as far, because I've heard people saying that there should be some prioritization of people with HIV or TB in South Africa for vaccination, because it's associated with a higher risk of case fatality. Well, why not extend that to diabetes? Or is that starting to become absurd? So what are the policy implications, potentially, of these findings? And I know you would be very, very careful to say this is very preliminary, it's a particular group of people, there are all kinds of caveats. But obviously we need to try and improve our policy on what we know as quickly as possible. And it sometimes takes academics out of their comfort zones in terms of saying, well, try this, try that, on the limited knowledge we have. And Alvaro, do you feel almost among your community who work on things like asthma, is there almost a sense of worry that this will now reduce the policy focus on asthma because it doesn't seem to be so important? I mean, I've been reviewing grant applications, I'm sure you have as well, where people take the things they're interested in and then explain why they're really important for coronavirus. And so can we have money to do the things we're interested in? And you've already spoken about this large asthma survey being suspended for all kinds of reasons. And I guess that's going to struggle to restart for the foreseeable future. So I'd just like to think through a little bit more, these are very selective findings, and we're at very early days of looking at these relationships. But what do you think the broader implications are, both for research and policy?
Well, Max.
Okay, should I start? So just a couple of points. So the data, the data showed on prevalence of diabetes and other NCDs. What I showed you was self-reported. So you're right, diabetes is probably underrepresented there. The HIV was from actual testing. And more recent research in the same areas actually tested anyone for all these conditions. I just didn't have access to those results right away. But so it's really just trying to give an idea of the age variation. But the data on diabetes in the slide I showed you on the risk of death, that is actually a complete different data set. I didn't do that research. And that's, as I said, it's using quite sort of sophisticated informatics to come up with a probable diagnosis. So it's saying you probably have diabetes if you've had certain tests and if the tests are above a certain level, or if you've been diagnosed with certain conditions, or if you've been referred to a diabetes clinic, all those sort of things. So it's a sort of probabilistic diagnosis. But those data, I would say, are about the risk of death in the population. Associated with these NCDs and other factors. I'd say that's actually very rigorous. It's probably the best data you're going to get of its kind anywhere in Africa. It's just the Western Cape province has just got better provincial health data than anywhere else. As far as is it known, is this knowledge about increased risk and risk factors for death, is that being disseminated? And I'd say it's very well known among health professionals. And there's also been tremendous efforts to educate the public and primary healthcare workers about all aspects of COVID, but including targeted sort of public health information on targeted at older people and people with NCDs. How well that's been and how effective it is, I don't know. I suspect it's probably quite variable around the country. Might just reduce to big posters put up in clinics, which might not be that effective. But certainly I'd say, among the doctors and nurses, I think they have a good idea of that. So could I pass on to Alvaro too?
Thank you. Max, Peter, everyone, I always tell the patients I see a lot of patients, that what they can do to prevent problems with COVID, if they have it, is to have the best health they can achieve by managing well their disease, preventing risk factors that could interfere with diabetes, hypertension, chronic respiratory disease, and so forth. And I think we need to convince policymakers and the public in general that infectious disease and chronic disease and non-communicable disease are interrelated, completely interrelated. The major risk factor that unfortunately we cannot modify at the moment when someone has COVID, other than aging, we can't really do much, seems to be diabetes and hypertension or cardiovascular disease. So the best thing to prevent problems with an infectious disease is to be in good health. The same applies to chronic respiratory disease. It seems that in chronic respiratory disease, as opposed to diabetes and hypertension, the management in short term protects people, and also they are protected by the fact that they are not exposed to other viral infections, or perhaps the fact that they fear much about their problems have changed their behavior into things that are not so risky. And I think respiratory disease, chronic respiratory disease, have been neglected, especially in the low and middle income countries, over years and years. And I hope we try to seize this opportunity to demonstrate that we need to see it as a whole, trying to avoid this terrible split between chronic and acute conditions, or non-communicable and communicable disease. It's important for research, for doing analysis, but in practice, we need to synthesize things. We need to put everything together. And I think this has been a problem in WHO. I worked there for 2 years, and I was really uncomfortable with departments that are split according to this sort of criteria, and didn't interact as much as I think would be ideal. But we need to move forward, and I think moving forward is trying to put together all types of disease that may affect mankind, And the infectious diseases are important, but the background is non-communicable disease, and they are there everywhere, including the most poor.
Thank you so much. I think we're blinding some of our participants with our scientific knowledge. Oh, yes, we've just got a comment from my colleague Veronica from Mexico, saying we need to apply look at aging with a life course perspective and improve public policies, because we are looking at everything, each stage separately, and everything is integrated. So I think something that we would all agree with, that again, the issues of NCDs and coronavirus show that we mustn't look separately at different age groups separately. To some degree, perhaps we have to do that, but we also have to take a more holistic approach to looking at life course and health promotion, lifelong health promotion. I'm going to wrap up unless there are any more questions coming through. We just, firstly, a couple of general comments and then some thanks. Clearly, what we've seen today is that there are clear relationships between NCDs and COVID. Both specifically, we were looking at in these presentations about how NCDs can exacerbate risks associated with coronavirus. And in a way, understandably, a lot of people working on NCDs at the moment are looking at that. But we mustn't lose sight of the fact that regardless of whether or not they are associated with coronavirus, NCDs are extraordinarily important in their own right. And so the finding, for example, that hypertension is not very significant in terms of adding to the risk of case fatality for COVID, shouldn't obscure the fact that hypertension is the leading risk factor for deaths for people at all ages in the world, and has been for many years, and is in many ways something that we can deal with. And again, I'm slightly concerned that we're starting to see research framed around this notion of excess death. And I think on one hand, that's very helpful, saying, well, look, if we compare deaths in 2020 to comparable periods in previous years, we can see that there have been a lot more. And we can call this excess death. What we lose sight of there is that in those earlier years before the pandemic, very, very large numbers of deaths were relatively easily avoidable, particularly NCD deaths, or also infectious disease deaths. And in fact, the numbers of avoidable deaths before the pandemic are far more than the numbers of excess deaths as a result of the pandemic. So sometimes I think this sense of relative scale of these issues gets rather lost in the way that they're being framed. The idea that now we have excess death in 2020, which is only understood in terms of what it was in 2019 or 2018 and the difference. Well, I would say that there was a lot of excess death in 2019 and 2018. So I think even semantically, we have to be extremely careful about the way these issues are being framed. That is all I have to say. I just want to thank Max and Alvaro so much. From my own very personal and selfish point of view, this has given me, it's raised a lot of questions, as is always the case, and it's helped me think more carefully about what the questions are, but it's also started to offer some tantalizing evidence about some of the answers to some of those questions. So I found it extremely instructive and helpful. Have you got any final points you'd like to make before we sign off?
No, thanks, Peter. Thanks for inviting us.
Okay, well, sorry, Alvaro? Okay, well, thank you so much. And everybody do keep an eye on the Global Platform website because we will be organising another webinar next month, possibly on policies focusing on delivering vaccines to older people in low and middle income countries. But that's to be confirmed. Thank you. Goodbye.